So I'm going to be talking about missed opportunities of vaccination and then the second year of life. These are relatively well, they've been around, but there's been a lot of emphasis now, a lot of focus on how to get these things right. Because traditionally there hasn't really been strategies to address them. So these are sort of emerging areas. So the outline of my presentation, I will talk about the MOVs, the missed opportunities. I'll give a snapshot of what the issues are, show a little bit of data, and then I'll talk about the second year of life and in the context of a Lifecourse approach, so not as an independent sort of visit. Challenges we had with second year of life, and then opportunities, because there are challenges, but then there are opportunities to actually fix an issue and also tie it to strengthening a health system in general. And then I'll share some of the country experiences we've had with data recording and reporting tools. And then we'll end with some group work where we would look at, if you did bring your immunization or tools registers, we'll take a look at that. If you don't, there is a register that I would share, and then we'll work through that. And then we'll do what we call a SWOT analysis. And the goal there is really try to think about how to improve your current data recording and reporting tools. So this is going to be the outline. And for this initial talk, I'll try to keep it with the questions and answers to about 3 p.m. I know there's supposed to be a fire drill, so that's going to be another opportunity for us to get up and stretch again. All right, so moving on. So missed opportunities, what is the definition? And this is what it is. Any visit to a health facility by a child or adult, I'm reading this because it's important, who is eligible, that's the key word, eligible for vaccination. So that's if they're unvaccinated, partially vaccinated, or not up to date, and free of any contraindications for vaccination. And which does not result in the individual or that person receiving all those vaccines that he or she was eligible for. So this is the working definition for a missed opportunity. All right, now we're going to do a little short exercise. So can anyone tell me the potential for a missed opportunity here? And please use your microphones.
I think tetanus.
You think tetanus, okay. Can anyone else, what they think would contribute to a missed opportunity here? Yes. DPT, anyone else? Yes. False contraindication, very good. So we can look at this picture in many different contexts. I think some of you were looking at it in terms of, all right, the physician is thinking about the vaccines, but they don't have everything listed. That is not inaccurate. That is also correct. You can look at it from that perspective. And someone mentioned a false contraindication, which is correct, because you can also say that the physician looks at the child with the broken arm, and that might be a contraindication for a vaccination. And so by default, they would not attempt to vaccinate them. Yes, that is true. But what actually happens in physicians' offices? When a child comes for some sort of care outside of the immunization sphere, do all physicians look at the child's immunization card or automatically think about the need for vaccines? Does that happen on a regular basis? It doesn't. So that's a missed opportunity right there. So these types of situations contribute to missed opportunities. Now let's look at another one. What about this one? What is going on here? And please don't be shy. There are no right or wrong answers here. It's a matter of just talking about the issue. Stock out, yes. Anyone else? She mentioned stock out. She doesn't know what vaccines should be provided. Okay, anyone else? Yes, both of those two are correct. The child comes, the child has the card, the vaccination card. Nurse is thinking about providing immunizations. There's stock out, there's nothing there. So that's a potentially missed opportunity because she's unable to provide a child with a vaccine. All right, one last one. Okay, what's going on here? Of course, it's a pregnant woman. She has an antenatal care card. and there's a little child, right?
Sorry.
Yes.
The center only cares for the beneficiary who is coming to take the service without looking overall at the family health.
Thank you very much. So that also happens. The caregiver is most likely going to try to attend only to the mother and would ignore the child. And you can actually extend this. Let's say that the healthcare professional, not the healthcare, let's say the caregiver came to an immunization session with 2 children. One child was eligible to receive vaccines. A lot of the time, what also happens is that the healthcare worker might just look at one child without looking at the other child. There's so many different iterations of what results in missed opportunities. So what am I trying to portray here? That some of these things, they might look so simplistic, but if the healthcare worker is not automatically thinking about this because they are used to doing things a certain way, they are not going to remember what to do, and it's going to result in a potentially missed opportunity. So let's move on. So some of the common reasons, a lot of these you've already mentioned, but we can still go through them. So the history, the child's immunization history not being reviewed by the healthcare provider, of course, that's something we know. There's a reluctance to open vaccine vials sometimes. So, and I'm sure you can relate in your country context. I'll give an example about a 10-dose vial of measles. If I have a 10-dose vial of measles and I'm the nurse, and a mother comes with 1 child, do you think I would be tempted to open that vial? By law, or the country provider, you're supposed to, even if it's 1 child, you're supposed to. But what happens a lot of the time, the healthcare worker will tell you that I'm wasting the vaccine, and so I'm not going to open 1 vial because there's only 1 child. But you really should. You're protecting a child. No single child should be without vaccinations. We know that. But you need to get people to think about this. And sometimes the healthcare workers are scared that they're going to get into trouble with their whatever supervisors, so they don't do that. But it's our duty to, make it clear that even if there's a single child, you really should provide those vaccines to them. So the reluctance, the forgetfulness of healthcare providers. You're busy, the child comes with a different condition other than, vaccination. Yeah, you might forget, so that's true. The perceived contraindication, that's something we saw. And then the logistical issues, which is the stock out and vaccine, cold chain failure. Those are things to consider. Economic considerations are also there. They are a bit rare, but that's something to be taken into consideration. I'm not checking my email. I'm just making sure that I'm keeping to time. Okay. All right. So moving on. Now, I want us to take a look at these again in the context of access, in the context of equity, and then also in the context of in the context of opportunities for doing for improving a system. So, what do we all know about equity? When we are able to get these things right, does it improve or decrease equity? It improves equity. So that is fairly simple. Now let's look at this also in terms of special populations. How difficult is it to miss children who are, for instance, nomadic or who are, for instance, migrant? Think about that. Here you have a situation where I'd say you're in a controlled environment. You're bringing someone to a certain place. But let's say that you're going out to provide services to some migrant population. Do we automatically think that it's very difficult tracking a certain population, and so when we're going out, we should think about every single medical or every single type of care we can provide the child? Do we integrate the services? So if maybe a malaria group is going out to provide malaria prophylaxis, can we tie that into the immunization program, sort of working together with that group? Just provide comprehensive care so you're not doing one thing at a time, because it takes a lot of resources to go out every single time. So when we think about these things, it's not an issue of it's so difficult to fix, but we can actually help address some of these things from what we already do. And that was one of the things that I think was mentioned yesterday. This was about the data. We have tools that we can already use to improve things. And same vein here, the things that we already do, we don't necessarily have to change everything. We can sort of work, integrate, or sort of improve them based on the new challenges we see. Okay, so MOVs, how often are they, do they occur? In 1983, this was when WHO convened a group to sort of understand what the issues were. So I'm going to ask a question. When there was a survey done in 1993, can anyone give me an estimate of the prevalence global of MOVs back in 93? Let's mention a number. 60%? 40%? Okay, so it was 32 global. But of course, when you look at different regions, it extends. So some region might be 40%, some might be slightly higher, depending. But this was the global prevalence. And then in 2005, this is the GIBS, that strategy, and the red approach. The issue was, how do we try to fix those issues with MOVs? Those were some of the thought processes in improving immunization systems. There was another survey done in 2014. Can anyone guess what the current prevalence, or the prevalence in 2014 was for MOVs? Is it less or more than 34%? Okay. 32, the same. So what have we done? Net gain 0. That's not good, right? So we have to work harder at these things. They are real problems. They are affecting the children. The children are not getting vaccinated. We need to do something about these. But it's for us to recognize that it's a problem, try to understand it within our country's context or situation, and then find ways of trying to improve it. So I know WHO is working on a strategy to actually figure out how countries can work to identifying incident or whatever, the burden of MOVs in their country, and then also provide guidance for what they really should be doing to try to fix this issue. So I'm not going to go through this 10-step process. The documents, I believe, are online, WHO, but this is something that I can share with the facilitators so that you have access to them. And in the same way, they do have the strategy from how to plan to the implementation phase. These are all very well laid out. So again, these are things that I'll share when I have access to them. Okay, so strategies to improve or to minimize MOVs. I've already talked about the guidance documents. Intervention research is important because you need to know what the issue is if you're going to fix it in your country. And then the second year of life is an opportunity. I will talk about that. So we would make a link between how that platform might reduce the MOVs and also actually help strengthen the health system in general. So I've been working a lot in Ghana doing a second year of life project, which is very extensive. And let's quickly, one of the issues we found in Ghana was that they had introduced meningitis A vaccine last November. At the same time as when the second dose of measles was provided at 18 months. The issue was that the healthcare workers were very confused as to what to do. So for instance, if a mother brought her child for the 18-month visit, they would only provide the second dose of measles, and they would say, well, you can't take meningitis A because they shouldn't be given at the same time. Or they were also getting confused about the ages. So if a child came in, they were 21 months or 19 months, sometimes they just send the children back home because they would say, your child is too old to receive the vaccine. So it wasn't very clear. And that was a problem we found across the country, and we had to quickly do something about this. So they developed this very simple flowchart. Of course, it had some problems when you look at it critically, but when you think about it, it's a very simple tool to help a healthcare worker who is at the very front line think about what she should do when she's presented with a challenge like that. So I'm not going to go through it, but basically, when you look at it, the healthcare worker should be able to segregate it, well, not segregate, look at the child by age and determine what vaccine they are supposed to receive for that particular visit. And then if they are supposed to come back later, then it's also there. So simple tools. So simple tools might go a long way. That's really what I'm trying to show here. So I'm going to transition now to second year of life. And again, I'm looking at the time, not my email. Okay, we're doing good. I can be your timekeeper. Oh, great, that would help. Okay. Thank you. Maybe 20 minutes. 20 minutes. Yes, thank you. I got 30? Excellent. All right, so second year of life. EPI programs, you all know what it is. I'm not going to go into that. But this actually contributed to some of the problems because we had those initial 6 antigens. And I kid you not, there are places in the world where I go and people still mention 6 childhood killer diseases, even though there are so many more antigens in the routine immunization systems. Now, DTP is one of those indicators that has been used, but some countries have maybe pentavalent now with the addition of Hep B and a combination Hep B and Haemophilus influenza B, sort of combined with the DTP, so it's a penta. But still, DTP is a widely used indicator. So when we look closely at the coverage for DTP globally, what kind of stands out? Let's look at the left, my right. You're right, okay. Yeah, this tapering off, that is an issue. Because we're losing a lot of children. It's just sort of stagnating. So one of the things the second year of life concept sort of tries to help with this issue here is to catch those children, provide a safety net, where the children that were missing because of this leveling off would have another opportunity. And this slide here shows the number of countries in all the regions that have at least one vaccine during the second year of life. So when you look at the red rectangle, there's a lot of countries, and this number is just going to keep increasing. So for me, it's a great opportunity because I know that those children that are being missed for whatever reason during the first year, they have another opportunity here. But we need to engage those healthcare workers. We need to engage the caregivers to understand that immunization doesn't just stop at 1 year. It goes on, right? It's a continuum of care. It's not just a single event or a single time point. And then quickly, the whole concept of a life course approach. We have to be careful not to make the same problem or repeat the same problem which has created what we have. Which is just emphasizing one particular time point. When the advocacy was for those 6 childhood vaccines initially, that's what stuck into people's minds. So for now, we're being very careful not to just mention second year of life. Then it's going to cause another problem where, let's say, a vaccine is introduced at greater than 2 years, then we have to try to change those mindsets again. But quickly, we're trying to make sure that they understand that it's a life course. It's the second year, it's just a single time point, and not necessarily the best. Yes, it has its benefits, but it doesn't stand on its own. It's a continuum of care. So that's the goal here. And this is all supported, when you look at the GVAP and GRISP, these are all concepts that are in there. So it's not something that is just made up, but something that really is supported by countries. Okay, so now challenges for that second year visit. This is slightly old, I believe by a year, but the trend is fairly similar, so apologies for not updating this. But we do see that there's a difference between first dose measles or measles-containing vaccine and the second dose. And we pretty much see that in every region. It's not necessarily because countries that introduced, countries only recently introduced second dose measles. There are countries that have introduced it for a long time and are still struggling. And the next slide that I want to show here, this is the Afro region. Again, it's a little outdated data, but the trends are fairly similar. We did hear that countries that have high first dose coverage typically do very well. But that's not what we see here, because every country here has greater than 90% coverage for the first dose measles, and they are still struggling with a second dose. And some of these countries have introduced second dose measles or have introduced it for a number of years. So it's not, so what I'm trying to say is there are issues with this, with introducing a new vaccine at a different time point. It's not so easy. Those strategies that work during the first year might not necessarily work in the second year. Some of those challenges are extremely unique.
Are these all the second year of life schedule, or it's by schedule?
No, this is all second year of life schedule. Yes. All right. So again, I would go back to the country situation in Ghana just to make a point. When we started looking at Ghana in comparison to most of its neighbors or countries in Africa, their health system was really strong. They have fairly good coverage of the first dose of their antigens provided during the first year of life. So when you see here, the areas in green are about 90% coverage, and then you only have a sort of few scattered areas. So we knew they were having problems with their second year of life. And they would say, well, it's only a number of areas that have those problems. It's not really a widespread thing. So what we decided to do was to look at the district level maps and try to figure out what the real issues were. Now, what I'm adding is the second dose of measles. Then it becomes very clear what those equity problems are. It's not just a matter of there's a particular area that is struggling. It's cut across. So yes, those problems with access, they are very clearly laid out here. So for something like this, the country could not be in denial and say that, well, it's only a limited number of places, but it's pretty widespread. So we really need to think really hard through this. All right, so moving on, the demand side challenges. So this is at the caregiver side, the community side, etc. What have we seen globally about challenges for introducing a new visit during the second year of life? So the lack of culture, or the lack of culture or the awareness, that is a big problem. So if some caregiver doesn't know that there's a visit in the second year of life, you don't expect her to bring her child for vaccination services. She doesn't know. You can't really blame her. She needs to know. Now, the perception of low disease risk. I've heard several places that when the child turns 12 months, they've gotten a lot of the vaccines. The child is healthy. Why do I need to send the child back for a service? For immunization service beyond that 12 month. So that is the perception. So that needs to change. It involves change in behavioral knowledge attitudes, and it's not very easy doing that, but it needs to be done. The lack of communication. And I do see a lot of countries introduce new vaccines and they don't have a very good communication strategy. It's not just about blasting something on the radio or the TV or printing a bunch of posters and putting them up. That alone does not work. No, you're trying to change a behavior. People are used to doing something in a different way. So just doing something superficial is not going to solve it. We really, really need to work really hard at this. The stakeholders. They all have a role to play. So if you have, for instance, and I'm going back to stakeholder, tying that to the initial talk we had today about private providers. For countries where, for instance, private providers play a significant role in immunization, you will need to really engage them when it comes to introducing a new vaccine, because they are playing a role. You can't just say that, well, this is the government thing and we're going to try to run it whichever way we want. That's not going to help. You're going to have those gaps. So who else can we think about? What if it's involving your universities or some regulatory agency? They all need to be in this together. It has to be something that's collectively done, not necessarily led by one entity, if we want this to be sustainable and we really want this to work. Then other things that might seem trivial. So let's say that a woman in a rural area has to walk 2 kilometers, or 3 kilometers to take her child to a facility for immunization services. What happens when the child is over a year old? They are bigger, they are heavy, they scream, they are stronger, they fight the nurses, they bite. So that is a reason for a woman not wanting to take her child. So those considerations cannot be swept aside. You have to think about them. And then, of course, the logistical challenges. Most moms are working now, but it depends. I can't generalize that. Some places, mothers are working a lot more, so the children are maybe in school. The mother cannot leave work to go to school to take her child. But that is a potential reason why we have this demand challenge, a challenge with the demand side. And then for the delivery side, which is the health facility side, again, the planning issue I've talked about. If you don't plan carefully, if you don't take everything into consideration, it results in issues. There is also that perception among healthcare workers that immunization ends at a certain time point. So I've seen healthcare workers tell me that, no, I don't vaccinate after the child is past 12 months because the child is not eligible for any vaccine. I've seen that. with my own eyes, and we've done a bunch of surveys to prove that. So yes, it is a problem. Healthcare worker trainings. So you know, one of the things I believe in December or November last year, the Gates Foundation convened this workshop on how to look at training for healthcare workers. Because a lot of the times what happens is you have someone from the national level come to training, maybe they get a per diem or whatever, and then you're expecting information to be pushed down to the lower level. When you go to the lower level, what do you find? Either the information is not there, it's very dilute, so what's the point? Right? So we have to rethink how these things are done and how to critically make sure or critically think about how to get information down to the very lower levels. If it's the frontline healthcare worker providing immunization services, they need to know what to do. Yes, it's good a national person knows, but at the end of the day, it's the nurse or the front lines providing the vaccines. If she doesn't understand the schedule or she's confused about the policy, she's not going to do a good job. All right, so wastage consents. I gave an example about a 10-dose vial, so that's very relevant. The data issue, we cannot avoid that. So we're actually going to do a bunch of exercises on how to improve the accuracy of our data reporting and recording tools and things of that nature. But that's going to be very relevant, and I think that is one of the objectives of this workshop. And then the policies. So again, the policies sort of guide what is done. If there's no policy, you can't hold someone accountable for doing something wrong. So we need to get those right. And then the workload of the healthcare worker. And I'll give you a typical example where in one country, we were trying to get nurses to go to the schools to provide vaccination services. The reason being that school attendance rates were very high. And the nurses said, well, we can't go because we're so busy. So yes, it's relevant. We need to take that into consideration. And I don't know who Bastian is. All right, so moving on. Now, so what I'd said before was that, yes, there are a lot of challenges, but it's good that we don't look at them as challenges that are obstacles and just problems. They are silver linings. So I like to look at them as opportunities, not just to increase coverage, but to strengthen the system, if possible. It's not so easy, but that's what I like to look at them. We know of the measles rubella elimination goals. So if you're trying to get those coverages up for measles, well, if you don't get the coverages up, you're not going to eliminate measles. I mean, it's as simple as that. So when you have a second year of life platform that has the ability to catch children who have potentially missed the first dose measles, or actually increase that second dose, it's great because it brings you closer to the measles rubella elimination goals. So this is in the GVAP. I don't need to preach about that. But yes, definitely. So, and I think Gavi is supporting the new grant. All right. And then another opportunity, booster doses and new vaccines. I won't go through all of this. I just want to make a point maybe with the top two. So more than ever, we're seeing that depending on a country's situation or depending on the profile of a child, the child might have gotten 3 doses of a vaccine, but then you see that a child contracts the disease for which the vaccine was given, because maybe there's malnutrition, maybe there's some epidemiologic thing we don't know about. So then it makes sense for a booster dose to be provided to that child again during the second year. So we're seeing a lot of that, and pretty much this is what this slide intends to show. So the second year is a very important platform. It's not just about measles or meningitis A or some other vaccine, but the booster doses is very relevant to that. Moving on, Catchup. So Catchup is good. As I mentioned before, you miss a vaccine during the first 12 months. Then there's that safety net for you to come back and get caught up. Doesn't mean that we should encourage mothers to miss vaccines during mothers not to send their children for vaccines during the first year. But that if that potentially happens, there is an opportunity for them to get caught up. And then the second point here, the policies. Just because you have a policy doesn't mean the healthcare workers would always follow it, and I've seen that in several places. We need to constantly engage them. Again, it's a behavioral thing, so it takes time to get those concepts sort of firmly in place. And then MOVs, the last point here, this is in 2014. These numbers, you could potentially increase Penta 3 or what, DTP by as much as 10%. I believe global coverage is about, what, 86, 87% now, right, if I'm to get it wrong. So, right, but if you were to increase or you're to prevent MOVs and you were to move that into the 90s, that's very substantial, I think. So there are lots of opportunities, and I think that, and I hope that we all see, we all see this way. All right, so then I'll move to country experiences with data collection tools. A lot of the tools that I'm going to show here, well, pretty much all of the tools are from the Afro region, but it's supposed to be a guide, for us to think about what our tools look like for each of our countries, how can we improve them, what are some of the things that look so obvious to us, but really we're missing those special populations or actually contributing towards the equity problems that we're having. So we'll do a little bit of chatting here. So this is a Zambia community register, and I'd like to thank Rebecca Fields for this. She's done very good work on that, and I borrowed her pictures. What is wrong with this community register? What sort of stands out? Anyone? Any takers? Yes. The numbers. So, sorry, you said the numbers are going? Oh, it's increasing in number. Okay. Does anyone else have something else to say about this? All right, let me give you a clue. Look at the box that says fully protected. What is off about that? So let me put this in a context again. Just hold off 1 second. We are all public health professionals. We are very good at what we do. But you see that you look at something that looks very simple, and it's not so easy trying to find the faults. So look at this and also think about that frontline healthcare worker who does not perhaps have as much training as we do. And then they're trying to figure this out. I want us to be looking at both as we do this. Okay. So the issue here is fully protected. Now, you have a measles dose, and then it says fully protected, and then there's another measles dose, second dose measles. The healthcare worker is automatically thinking, oh, the child is fully protected. So if I'm the nurse, and then the child has gotten all the vaccines up to the first dose measles, and then I look at it, oh, it said fully protected. I probably would tell the caregiver, well, your child is fully protected, but you do know they are not, because they really should have come back, or they should come back for that second dose measles. I mean, you can make the argument that one dose of measles is highly effective, but I mean, if you really want very good protection, you should get the second dose. But this is a simple thing that can be fixed, but you could see how that can cause a problem, okay? Okay, now let's look at a child clinic card. This is for Zambia. What looks funny on here, or what can potentially contribute to a problem with equity? And I agree, it's not very easy. They try and go through these things. I just want you to be thinking about that as we go through. Very simplistic, but very challenging. All right, I'll show you what it is. Now look at measles. The measles. So it said what? Measles, 9 months, or soon after. What does soon after mean? 1 day, 2 days? What am I supposed to think if I'm the healthcare worker? Soon after. I can interpret it to mean whatever I want, right? Yes? All right? And then also look at the other vaccines where you see OPV 0, OPV 1. Measles doesn't have that convention. It only just has the measles. And the other thing is, so a child comes, let's see, the measles it says, 18 months. A child comes at 21 months. What is the healthcare worker thinking? It doesn't quite give her the guidance about what to do. All right? So let's move on. This is a Ghana health record booklet. Again, it's sort of a similar problem, so I'm not going to really go to that. But again, when you look at the measles, measles 1, measles 2, and one of the issues we saw about this type of thing was that you have a child maybe come at 21 months, right? And then you have 9 months and 18 months. A child comes in at 21 months, and then the healthcare worker would give them the shot of measles, but then they get confused as to where to record it. Some of them will record it at the 18-month mark. Some will record it at the 9 months. There's no clarity. It's a first dose, so it has to be recorded as a first dose. But it doesn't quite say how and where to record it. So when you look at the coverages, sometimes we see second dose measles higher than first dose measles. Not because of anything, it's because of a simple data recording tool that wasn't maybe well thought of, okay? And then one thing I want you also to think about as we're doing this is that, let's say that a new vaccine was introduced. This doesn't provide any way for that information to be captured. You know how it's sometimes very challenging or very expensive to print records or data tools. So when you're developing something, you're going to have to be thinking long term. All right, maybe for the next 5 or 10 years, if I don't have any money to print or to print a data collection tool, how do I make it so that it's so robust that even if there's a new vaccine coming into the system, there's a way for it to be captured? So these are some of the things we think about. Or we have a lot of special populations. Do we even capture them at all? Do we have that in there? So some countries that do not, or they completely separate out those who are considered locals of the country versus those who are considered coming from if they are refugees or things like that. That is one thing. Some countries also would vaccinate whoever, but maybe if you want to vaccinate someone who's a refugee, but you don't want to count them as being part of your own, I'm just giving a hypothetical example, how do we still capture them? So how do we think about those types of things? Okay. And then this is a tally sheet. This is Senegal. Let me just quickly go through here. So here again, we see that it says measles 1, measles 2, but then we have an issue with age. So if someone came and they're outside of the age range, again, that's a problem. Where are they supposed to be fitted? I mean, where are they supposed to be incorporated, or how is this supposed to be accurately recorded? All right, and then, I'll quickly show this. This is Kenya. They actually did an update of this tally sheet. But what it was before was they also had that issue where it wasn't very clear how to record the doses and the age groups. And so what they've done is that for measles 1, for instance, they said under 1, so that there's an opportunity for it to be recorded, and then above 1. And then for measles 2, it clearly states 1.5 years to 2 years. So they're clearly indicating the time interval based on their immunization schedule, where the child, or when the child should be vaccinated, and also above 2 years. So, they're trying to solve a problem. So these are the type of things that I want us to be thinking about when we have the time to work on the immunization register, which we'll be doing later on. All right. So what are some considerations for improving our data collection and recording tools? Yes, again, we need to involve all stakeholders because, as we can tell, everyone has a role to play. It's not just the work of the immunization program. Everyone needs to sort of contribute. There needs to be very good planning, all stages, and not just, well, how do we change it, but who's going to pay for it? Who should we also consider in that process? Are we missing anything at all? You have to critically think through all these phases and have a plan about how to do this. And then I think you don't just change one tool, because usually there is a collection of tools for gathering data. I'm yet to see any country that has one tool, unless maybe you can make a case for a country that only uses an electronic system, but usually they're paper-based systems. So you have to think about how do we change every single tool, not just one. And then the pre-testing is important, and for a number of reasons. I've seen registers that are so big and so heavy the healthcare worker will tell you there's no way I'm going to be able to carry this to do an outreach or to, to provide a service somewhere else because it's just too heavy. So maybe when you are designing this and you have the inputs of the person who is actually using them, that also sort of guides how you develop them. So thank you. I'm not done. But yes.